Upstate Medical University in Syracuse, New York invites you to be the informed patient with the podcast that features experts from Central New York's only academic medical center. I'm your host, Amber Smith. Living with a chronic medical condition can be stressful. Today, we'll be focusing on the challenges of diabetes. My guest is psychologist Lisa Harrell from Upstate's Joslin Diabetes Center. Welcome to the Informed Patient, Dr. Harrell.
Thank you. Happy to be here.
We'll be talking about diabetes distress. Can you explain what that is?
Yes, diabetes distress is a range of concerns and worries that are a normal reaction to living with and managing diabetes. So it's not a psychological diagnosis. It's the routine sadness, anger, frustration that really expresses the worries and concerns that you would have living with a chronic illness.
So the symptoms are sadness. What are the other symptoms?
Anger, frustration, anxiety, and worry. You know, diabetes is a illness that affects your entire body, and you're trying to manage your glucose level, that is the blood sugar that you no longer are effectively able to manage, either because you've developed the insulin resistance of type 2 or you no longer produce insulin, which is a hormone that opens up our cells and allows sugar to come in and nourish us. And so when that happens, you're living with an illness that you will need to treat for the rest of your life. And it's going to require daily management and impact your routine on a daily basis. And there are potential lifelong complications you can develop if your efforts to manage it aren't as successful as you'd like.
Who is likely to be affected by diabetes distress? Is it everyone who's diagnosed?
Yes, and at any age, you can develop diabetes distress. It can start with the initial diagnosis, which can come as a shock to some people that they have been diagnosed with diabetes. For many years, for example, we thought type 1 diabetes happened only in childhood, but there are adults who are now being diagnosed with type 1 diabetes. And when they learn of it, there is a reaction that we have to learning about having a healthcare problem like this. So it can be from the initial point of diagnosis, or it can occur later as you've been dealing with diabetes day in and day out for many years. The distress can occur at any time. It can happen with children as well as adults. They estimate that for type 1 diabetic children between the ages of 8 and 17, 28% of them are experiencing diabetes distress. And adolescents, a third of them with type 1, type 2 diabetes are experiencing diabetes distress. Women are more likely to describe experiencing diabetes distress than are men. And that may be because women are more readily interested in talking about their feelings and concerns. And then people of color who are at higher risk for diabetes are reporting high levels of diabetes distress, perhaps because of the impact of social circumstances on their access to medical care and to paying for the medical care. So it can happen at any point in time in life.
Is the distress measurable? Is there a way to determine how severe the distress is?
We have two scales, one for type 1 diabetes and one for type 2 diabetes, that are available online at https://diabetesdistress.org. And these instruments, the type 1 diabetes or type 2 diabetes distress assessment system, can be completed in about 5 to 8 minutes and scored immediately with feedback. And they are a self-rating scale from 1 being no pressure or distress or impact to 5 being high levels of impact and emotional burden from your diabetes. And they give you a overall score, and then they give you source scales. That is the scales of particular kinds of concerns. For example, the financial cost of diabetes might be high for some and not so significant from others. Or some people may be more concerned about their blood sugar going very low, which we call hypoglycemia, which is an unpleasant and potentially dangerous state to be in. and they may have fears about that. Others do not. So you get both an overall score and then you get subscale scores that let you know where your diabetes distress is more prominent. Any score over 3 is considered severe diabetes distress, but between 2 and 3, it's worthy of seeking some sort of counseling for coping with diabetes.
So it sounds like the distress could fluctuate day to day or week to week.
It could. Distress is the normal emotional toll of living with this chronic demanding condition, feeling overwhelmed and guilty, etc. And it can come and go, but it's generally involves negative emotions. So about a third of the people to a half of the people in any given time period will be showing some degree of diabetes distress.
Now, what effect does the distress have on the disease?
Scientific reports indicate that distress is consistently associated with higher A1C levels. Now, A1C is the average blood sugar level over a 2 to 3 month period, and it shows the percentage of your red blood cells hemoglobin proteins which have become coated with sugar. And when your percentage is 5.7% or below, you don't have diabetes. But if it's over 6.5%, then you do. And the range between that is the range where we talk about prediabetes. So A1C is used both to diagnose diabetes and also to determine how well the treatment plan that you have in place is working for you. So to have higher A1C levels because of your diabetes distress suggests that the treatment maybe needs to be adjusted or you're having difficulty managing it. And so we get these higher A1C levels because diabetes distress will interfere with the daily management of diabetes and it places you long term at greater risk for complications. So that's why it's very important to manage diabetes distress. And when we do, we see that the A1C levels go down.
This is Upstate's The Informed Patient with your host, Amber Smith. I'm talking with Dr. Lisa Harrell. She's a psychologist at the Joslin Diabetes Center at Upstate. So let me ask you about the daily self-management requirements of diabetes that can lead to this stress response for our listeners who don't have diabetes. What is it like living with diabetes?
Well, it's very labor intensive. You need to monitor your blood sugar level daily. And this is true for both type 1 and type 2. Initially, type 2 diabetics have a somewhat easier time of it until, the disease, it sort of advances for them, and maybe 40% of them are taking insulin after 10 years. But for type 1 diabetic, you're monitoring your blood sugar level when you get up in the morning, before every meal, before you go to bed at night. You're checking your blood glucose level before you get in the car to drive someplace. And if you're leaving the house to go for an appointment or to exercise or something like that, it's important that you pack a snack that will give you an instantaneous boost to your sugar level if you start to go too low. So the constant monitoring, managing your diet, managing your exercise, and frequent medical appointments to see your endocrinologist every 6 months, but also to visit with dietitians, educators, other medical specialists as needed, makes for a life that's pretty much your routine needs to incorporate and focus around diabetes management. The ADA says it takes about 2 hours a day to manage diabetes. That's a lot of time out of somebody's day. For type 2 diabetics, the amount of times in a given day that you need to monitor your blood sugar level might be less than that for somebody with type 1. But you're also taking pills, you're controlling your diet, you're controlling your exercise, you have many health professionals you're seeing. So this is a labor-intensive disease that you need to think about all the time. You're always going to need to manage it. You cannot take a break.
Well, let's talk about possible solutions. Can anything be done when a person is first diagnosed that can help lessen the chance of diabetes distress?
I think it's really important for people to be aware of the possibility of diabetes distress developing even from the get-go. So doctors are frequently the first people that patients will talk to about their feelings of stress and unhappiness, even mental health concerns. So I think it's important for doctors to have good conversations with their patients, normalizing a negative reaction to having a diagnosis of diabetes or to having to manage it or feeling disappointed in how the management is going. And then doctors are then in a good position to talk with their patients about maybe getting some mental health therapist involved to help them better manage their diabetes or manage their emotions relative to it. So an open attitude, a normalizing attitude, I think are very helpful, and recognizing that diabetes distress exists. Sometimes people are surprised that what they have been feeling and struggling with all these years has a name and that there are ways to help them with it.
So when a patient is referred to someone like yourself, a psychologist, to, talk about the distress that they're feeling, how do you determine if it's I don't I don't like the word routine, but routine diabetes distress versus depression?
It's important to know that people who have diabetes are at higher risk for depression and anxiety disorders. But the difference between diabetes distress, which is a normal reaction, and depression and anxiety disorders has to do with whether or not they have the symptoms of those disorders, the length of time, and that they are disruptive to their life in a general sort of way, maybe their occupational functioning, their social functioning. We use a diagnostic and statistical manual in its fifth edition that we can use to make a diagnosis of depression. So, for example, with depression, a person has to have both either a depressed mood or a loss of interest or pleasure for the last 2 weeks, and then several other symptoms. For example, fatigue, loss of energy, feelings of worthlessness and guilt, maybe some suicidal ideation, things like that start to move you into a clinically significant diagnosable range of depression. We routinely screen for depression at Joslin uh, using the PHQ-2 and 9, and that helps us to know whether or not we have patients coming in who are starting to look like they might be depressed and then need to be seen by a mental health professional right away for that. And then we carry it forward using our diagnostic and statistical manual. Patient histories, all these kinds of things can help us to clarify the diagnosis and discriminate between diabetes distress and something that is a more clinically significant disorder.
So for diabetes distress, what sort of coping methods are you likely to suggest?
We use a lot of evidence-based therapies, including cognitive behavioral therapy, dialectic behavior therapy, emotion-focused therapy. These are therapies that teach skills and address this thought and beliefs that people have in relationship to something that's going on in their life. It's thought that if you can change your thoughts and attitudes about an event, you can change how you feel and you can change what you do. And so much of our effort is involved with teaching skills for managing and controlling your thinking, teaching relaxation skills, teaching ways to be more assertive in addressing your needs, and using this skill-based focus and mindfulness strategies, we can help people move out into a different direction and start to cope differently, think differently about the impact of diabetes on their life. And we can also use emotion focused therapy, which might focus on, well, I understand that you have these negative feelings over here, but instead of doing the things that tend to contribute to perpetuating the problem, what if we tried something different? What might that be? And so that becomes an effort to develop a different plan for behaving and responding to stressors. So those are the kinds of strategies we use to help shift people away from feeling distressed and feeling more empowered and able to control and manage their diabetes.
Do you have any advice for friends and family members for how they can recognize that a loved one is in distress or what they can do to help that person?
I think it's always very helpful for family members to be talking to their loved ones about how they feel about having diabetes, what's hard about it, what kind of help they would like to have, what are they worried about. I think people with diabetes appreciate very much if family members and friends really learn as much as they can about diabetes and make themselves available to be supportive. One way that I see patients having family members and friends support them is by having some of the continuous glucose monitor, something technical device you can attach to your body that can measure your sugar level in your bloodstream continuously. That data goes to your phone. It can go to your family member's phone too, so that they can be a backup plan for you. But at the same time, encouraging and respecting the person with diabetes' ability to manage their own diabetes. And usually, if you engage in these conversations, you'll hear that the person feels frustrated, sad, or angry. You might hear them complain about caring for their diabetes, and that would be the time when you can let them know, I hear you, I understand how challenging this is, and would you like to talk with somebody about it? And perhaps go with them.
Well, this has been very informative, and I want to thank you for your time, Dr. Harrell.
Well, thank you very much, Amber. It's been nice talking with you.
My guest has been psychologist Lisa Harrell from Upstate's Joslin Diabetes Center. The Informed Patient is a podcast covering health, science, and medicine, brought to you by Upstate Medical University in Syracuse, New York, and produced by Jim Howe, with sound engineering by Bill Brokel and graphic design by Dan Cameron. Find our archive of previous episodes at upstate.edu/informed. If you enjoyed this episode, please invite a friend to listen. You can also rate and review the Informed Patient podcast on Apple Podcasts, YouTube, or wherever you tune in. This is your host, Amber Smith, thanking you for listening.